of neck, this fascia is named as cervical fascia, which consists of two layers, which are superficial layer and deep layer. Okay, so it consists of superficial cervical fascia and deep cervical fascia. The superficial cervical fascia, as the name itself suggests, is the subcutaneous connective tissue, okay, which lies between the dermis of the skin and deep cervical fascia. Okay, superficial cervical fascia, which lies between dermis or between the skin and deep cervical fascia. And this superficial cervical fascia has one important content which is known as platysma muscle. As you can see in this diagram here, the skin has been reflected, okay, and this is the superficial cervical fascia. And one of the important content of superficial cervical fascia is this platysma muscle, okay. And this platysma muscle actually in human being is vestigial muscle, okay. It has no other function. It is vestigial muscles, but in case of animal, you must have noticed that they can move their skin over the neck, isn't it? This is because of the muscle platysma, but in human being, it is just vestigial muscle. And this platysma muscle, being subcutaneous muscle, it arises from the fascia covering the pectoralis major, okay, and the muscle ascend upward and medially. And they some of the muscle fiber crisscross with each other opposite side, and they get inserted at the base of mandible. Okay, most of the fibers get inserted at the base of mandible, but some of the fibers become continuous with rigorius muscle. You remember rigorius muscle, which is inserted at the angle of the mouth. Okay, so some of the fibers of platysma itself get continuous as rigorius muscle to get inserted at the angle of the mouth. So, beside platysma, the superficial cervical fascia also contains this cutaneous nerve, cutaneous vessels, lymphatics, and the fat, which is in present in variable amount. Okay, fat which may be more in like a well-built individual and less in the thin individual. So, fat distribution varies individually. Okay, so these are the content of superficial cervical fascia, and within that you must remember platysma muscle, which is the subcutaneous muscle. And then now let's go for the most important one, which is deep cervical fascia. So here in this diagram, this is the transverse section through the neck. Okay, the diagram is transverse section through the neck. Here, this is the anterior aspect, and this is the posterior aspect. Now, the deep cervical, so the outermost one is the skin, and beneath the skin is the superficial cervical fascia, okay, and still beneath the superficial cervical fascia is the deep cervical fascia. Now, deep cervical fascia actually inside the neck, or it forms collar around the neck. See, this blue color is representing the deep cervical fascia, which is forming collar all around. It is surrounding all around the structure present within the neck. Okay, so as it forms the collar around the neck, deep cervical fascia is also known as fascia coli. Okay, deep cervical fascia, as it forms collar around the neck, it is known as fascia coli. And this deep cervical fascia has various modifications, like it thickens and condensation occurs at different level to form different structure. Okay, so this deep cervical fascia modified at different six different regions mainly, which includes investing layer of deep cervical fascia. So these six modifications are the modification of deep cervical fascia. Okay, so to enlist investing layer of deep cervical fascia, as the name itself is suggesting, investing means it insert. Here, this is the investing layer. It insert all the structure or includes all the structure present within the neck, or let's say it encircles the neck. Okay, just beneath the skin and superficial cervical fascia. This is the investing layer of deep cervical fascia. The next is the pretracheal layer. Name itself is suggesting pretracheal layer, which lies just in front of trachea, is the pretracheal layer. Prevertebral layer, which lies in front of the cervical vertebra, prevertebral layer. And remember, the compartment which lies between the pretracheal and prevertebral layer is considered as the visceral compartment of the neck, because all the visceral organ or all the viscera of neck are enclosed within this visceral layer, visceral compartment. Okay, and then next one is the carotid sheath, which are two in number. Carotid sheath, which actually encircles the blood vessels and nerve of neck. So this compartment, or the compartment formed by this carotid sheath, is considered as neurovascular compartment. The next one is the buccopharyngeal and pharyngobasilar fascia. Okay, this buccopharyngeal and pharyngobasilar fascia are actually ill-defined fascia. So let's start to learn detail about individual layer, starting with the investing layer. Now here in this picture, the green color representation is the investing layer. As we have mentioned, investing layer encircle all the structure present within the neck. And this investing layer of deep cervical fascia has got superior attachment, inferior attachment, anterior attachment, and here posterior attachment. And we should know about these structures where this investing layer of deep cervical fascia are attached. Now let's say in this diagram, to talk about the superior attachment or the attachment of investing layer of the cervical fascia superiorly. Let's begin from behind forward. Firstly, it is attached at the external occipital protuberance. Now we are well known about all this bony landmark. No, we know external occipital protuberance. So the first structure to trust the superior attachment of investing layer of deep cervical fascia from behind forward is the external occipital protuberance. And if you remember the bone, external occipital protuberance, from external occipital protuberance on either side, a line extend, bony line extend known as superior knuckle line. External occipital protuberance, here it is not listed, superior knuckle line, then mastoid process, okay, and then partly to the cartilaginous part of external acoustic meatus, and then base of mandible, and from there to the symphysis menti. This is the superior attachment of investing layer. Once again, I repeat, from external occipital protuberance, superior knuckle line, mastoid process, external acoustic meatus, base of mandible, and symphysis menti are the superior attachment of investing layer. While inferior attachment is here, it starts right from the spinous process of scapula. Remember the processes of scapula, spinous process, acromial process are there. So it is attached to the spinous process of scapula inferiorly, okay, spinous process of scapula, and then from there to the acromial process of scapula, and then from there to the superior surface of the clavicle, and finally to the manubrium sternum. Okay, this is the inferior attachment. Spinous process of scapula, acromion process, superior border of clavicle, and superior border of manubrium sternum. So these bones we are all already acquainted with all of these bones. Okay, so these are the attached structure or superior and inferior attachment of the investing layer. Besides, anterior and posterior attachment is more clear from this diagram. So see here, this green color is representing the investing layer anterior attachment. So anteriorly it is attached right from the, it extends from base of mandible to the hyoid bone, and from there to the, see, this is the manubrium sternum. Okay, so from base of the mandible to the hyoid bone, and from hyoid bone to the manubrium sternum, upper border of manubrium sternum. So during attachment with its manubrium sternum, the investing layer splits into anterior and posterior layer. As you can see in this diagram also, the investing layer splits into anterior and posterior layer, so that anterior layer is attached to the anterior border and posterior layer is attached to posterior border of manubrium sternum respectively. Okay, anterior posterior layer splits. So this is about the anterior attachment, while posteriorly the investing layer is attached to ligamentum nuchae. So we are clear about this ligament as well, isn't it? Posteriorly it is attached to ligamentum nuchae and up to the spinous process of seventh cervical vertebra. This is the anterior and posterior attachment of investing layer. So can you recall, superiorly it is attached, can you recall structure? Superiorly, investing layer is attached to the external occipital protuberance, from external to the superior knuckle line, from there to the mastoid process, from there to external acoustic meatus, base of mandible, and symphysis menti. Inferiorly, spinous process of scapula, acromion process of scapula, then superior border of clavicle, and then to the manubrium sternum. While anterior attachment is from the base of mandible to hyoid bone, from there to the upper border of manubrium sternum, and obviously these two opposite structures are continuous with each other in anterior midline of the neck. Posteriorly, it is attached to ligamentum nuchae and spinous process of seventh cervical vertebra. Okay, so this is about the attachment of investing layer. Then let's go for the tracing of investing layer. Now, if you are clear about the attachment, then this investing layer can be traced horizontally as well as vertically. Okay, so to trace horizontally, this is the transverse section through the neck. Okay, representing here, this is the anterior part and this is the posterior part, because we can see clearly this is the body of the cervical vertebra and this is the spinous process. So obviously this is the posterior aspect and this is the anterior aspect. Now let's trace this investing layer here in this step. diagram, it is represented by this green colored circular structure is the investing layer. And to trace this investing layer horizontally from behind forward, starting with the ligamentum nuchae. Okay, so starting with ligamentum nuchae, the investing layer moves anterolaterally. Okay, anterolaterally, and at the posterior border, say this is the trapezius muscle. This is representing trapezius muscle. Exactly at the posterior border of trapezius, the investing layer splits to enclose the muscle. See, the layer is splitting to enclose the trapezius muscle, and at the anterior border, it again reunites. Okay, the investing layer splits to enclose the trapezius, and again at the anterior border of trapezius, it reunites to form the single layer. And this reunited single layer now, this forms the posterior triangle. So, have you heard about the anterior and posterior triangle? Have you heard about anterior and posterior triangle of neck? Have you?
Yes,
Are you there? Are you people listening?
yes, ma'am.
Okay, so leave it. So this anterior, posterior triangle and anterior triangle, there will be separate lectures in coming week. Okay, for now remember, posterior triangle is the triangle of neck present between trapezius muscle and sternocleidomastoid muscle on both sides. Okay, this is the posterior triangle. And then anterior triangle is the triangle present between anterior midline of neck and anterior border of sternocleidomastoid. This is sternocleidomastoid. So here, this is the anterior triangle of right side. This is the anterior triangle of left side. This is the posterior triangle of left side, and this is the posterior triangle of right side. So with this concept, this is posterior triangle, this is anterior triangle. So now see here, the investing layer splits to enclose the trapezius muscle. It reunites to form the roof of the posterior triangle. Remember, I repeat, it forms the roof of the posterior triangle. Okay, it forms the roof of the posterior triangle. It again splits to enclose the sternocleidomastoid muscle. Okay, and at the anterior border, it reunites to form the roof here again, roof of the anterior triangle. And finally, in anterior midline of neck, it gets continuous with its opposite side. Okay, this is the horizontal tracing of investing layer. Once again, to trace with horizontally from behind forward. Firstly, it is attached to the ligamentum nuchae. Then it splits to enclose the trapezius muscle. It reunites to form the roof of the posterior triangle. Again, splits to enclose the sternocleidomastoid. Reunite to form the roof of the anterior triangle and get continuous with its opposite value. This is about the horizontal tracing of investing layer. I hope you people are following me. Then let's go for the vertical tracing. Like we are just done with the horizontal tracing of investing layer. Now to talk about the vertical tracing. Vertical tracing means tracing the investing layer right from the superior attachment to inferior attachment, or vice versa, or from inferior attachment to superior attachment. Now we are clear about the superior and inferior attachment of investing layer. Okay. So during this vertical tracing, the investing layer splits at different regions, like it includes two glands within it. Within the vertical tracing of investing layer, the investing layer includes two glands which include parotid gland and submandibular gland. It splits at two different regions to form suprasternal triangle and supraclavicular triangle, and it thickens at two regions to form the stylomandibular ligament and parotidomesenteric fascia. So remember, stylomandibular ligament and parotidomesenteric fascia are the derivative of investing layer of deep cervical fascia. Okay, so from height bone, the investing layer moves upward. Then the investing layer of deep cervical fascia splits into superficial layer and deeper layer, so that it encloses the submandibular gland. See here, this is the body of mandible, okay, and here this represents the mylohyoid line, and this is the lower border or base of the mandible. So this superficial layer, which splits, which is split, the splitted part of this investing layer, superficial layer get attached to the base of mandible, while deeper layer get attached to the mylohyoid line, so that it encloses this submandibular gland. Okay. While in case of parotid gland, also this investing layer of deep cervical fascia that splits to form the superficial layer and deeper layer. Okay, here also the superficial layers move upward, covering the superficial surface of the parotid gland, and finally get attached to the lower margin of zygomatic arch. Remember zygomatic arch. Okay, so superficial layer get attached to the lower margin of zygomatic arch, while deeper layer is attached to the external acoustic meatus. Okay, so this superficial layer of this investing layer actually is thick and tough, which is known as paratidomesenteric fascia. Okay, so because of this toughness, condition like MOMS or parotitis may be very painful because it is not healing. Okay, these tough layers prevent expansion, and because of this parotitis, the condition is very painful. Okay, being the superficial layer or this paratidomesenteric fascia being tough. And then the deeper layer, which is attached to the external costic meatus, the part of the deeper layer get thickens to form the stylomandibular ligament. If you remember, stylomandibular ligament is a ligament which is attached to the apex of the styloid process to the angle of the mandible. Okay, so stylomandibular ligament is also derived from this investing layer of deep cervical fascia, and this ligament is what separates the parotid gland, upper parotid gland from the lower submandibular gland. We know location of parotid gland and submandibular gland. So this parotid and submandibular gland is separated by this thick stylomandibular ligament. Okay. So now we have talked about the enclosement of this parotid submandibular gland, and then now we are clear about stylomandibular and paratidomesenteric fascia. Now let's go for the suprasternal and supraclavicular triangle. So these two triangles are also the splitted part of the investing layer of deep cervical fascia. Here in this diagram, see here, the investing layer of deep cervical fascia splits to anterior and posterior lamina so that they get attached to anterior and posterior border of the manubrium sterna respectively. So this splitted part of the investing layer forms a triangle just above the sternum, and this triangle is known as suprasternal triangle or triangle of or space of bonds. Okay, this is known as space of bond or suprasternal triangle. As the location itself is distinct, lies above the sternum, so it is suprasternal triangle or space of bond. And this suprasternal triangle actually contained interclavicular ligament, okay, then arch of azygous vein, interclavicular ligament, then sternal head of the sternocleidomastoid muscle. These are included within this suprasternal triangle. Beside lymph nodes and lymphatics are there obviously. Okay, and to some extent fatty irregular tissue is also present. Then the next triangle is supraclavicular ligament. So here suprasternal triangle which lies above the sternum, and supraclavicular ligament lies just above the medial third of clavicle. Okay, we need to divide clavicle into medial third, middle third, and lateral third. Okay, let's divide the clavicle into three pieces. The supraclavicular triangle lies just above the middle third part of the clavicle. Okay, here it is also formed by splitting of this investing layer. See, this investing layer splits right above the middle third of the clavicle, okay, to get attached to the anterior and posterior border of clavicle and forming a triangular area known as supraclavicular space. And this supraclavicular space includes the supraclavicular nerve. Okay, it includes supraclavicular nerve as well as terminal part of external jugular vein. See, this is external jugular vein, terminal part of external jugular vein just before draining into the subclavian vein. Okay, so the content of supraclavicular triangle is terminal part of external jugular vein and the supraclavicular nerve are present within this supraclavicular space. So, are you people clear about this? We are done with this investing layer. Are people there?
Yes, ma'am.
Okay, we are done with the investing layer, and the next layer or next modification of deep cervical fascia is pretracheal layer. Okay, so pretracheal layer here once again let's get oriented with this diagram. This is transverse section through the neck, this is cervical vertebra, so this is the posterior aspect and this is the anterior aspect. And within the anterior aspect here, this structure is the transverse section through the trachea. See, this is trachea. So the modification or the expansion of this deep cervical fascia that lies in front of trachea is the pretracheal layer. So this much part is the pretracheal layer of deep cervical fascia. Now let's trace this pretracheal layer of deep cervical fascia first horizontally. To trace it horizontally, this pretracheal layer begins from the cervical fascia deep to sternocleidomastoid muscle. See, this is sternocleidomastoid muscle. So just deep to sternocleidomastoid muscle, this pretracheal layer of the cervical fascia begins here. Okay, then it forms the anterior wall of the carotid sheath. This is the carotid sheath, which is enclosing, as we have mentioned earlier, carotid sheath is the neurovascular compartment which include vagus nerve, internal jugular vein, common carotid artery, and its terminal branches. Okay, so here these are the structure included in the carotid sheath. About carotid sheath, we'll be coming in detail further. But now remember, the pretracheal layer begins from the deeper aspect of sternocleidomastoid muscle. Then it forms the anterior wall of the carotid sheath. Okay, anterior wall of the carotid sheath. Move further medially. Then now see here, the important part is this pretracheal layer splits to enclose the, what is this structure? This is the thyroid gland. Okay, right, left lobe of thyroid gland, and this connecting part is the isthmus of the thyroid gland. So entire part of the thyroid gland is enclosed by this pretracheal layer. Okay, so this is the horizontal tracing. Once again, I repeat, it begins from the deeper aspect of sternocleidomastoid muscle. It forms the anterior wall of the carotid sheath. Okay, then medially it splits to enclose the thyroid gland, and in anterior midline, it continues with its opposite side, or it continues with its opposite pelvic. Okay, so this is the pretracheal fascia. So if you remember thyroid gland, when we study about thyroid gland consists of, what are different capsules present within thyroid gland? What are different capsules present within the thyroid gland? True capsule and false capsule. True capsule and false capsule. Okay. True capsule actually is the derivative, is derived, or the structure derived by thickening of the parenchyma of the organ itself, not just in case of thyroid. कुनै पनि organ मा true capsule भनेको कुनै viscera को thickening of the parenchyma of the viscera itself forms the true capsule. And when we start about the false capsule of thyroid gland, if you remember that lecture, thyroid gland false capsule is derived from pretracheal layer of deep cervical fascia. This is a sentence what we studied, isn't it? False capsule of thyroid gland is derived from the pretracheal layer of deep cervical fascia. So this is the thing. Here it is the proof. Okay, pretracheal layer is forming the false capsule of the thyroid gland. So are we clear about the pretracheal layer horizontal tracing? I hope you people are clear, right? तिम्रो बोल्दै बोल्दैन अब बुझेको नबुझेको केही थाहा छैन. So this is about the horizontal tracing. And then let's go for the vertical tracing here. Vertical tracing of pretracheal fascia is, it begins from the hyoid bone. Okay, from hyoid bone, the pretracheal layer descends downward. Then it get attached to the oblique line of thyroid cartilage. Thyroid cartilage on its anterior aspect has oblique line, okay, on either side. So it get attached to the oblique line of the thyroid cartilage. Further descend downward, get attached to the cricoid cartilage more laterally, okay. And from cricoid cartilage, it descend down and it splits, and this layer is splitted to enclose the thyroid gland. Okay, हामी horizontal tracing मा पनि यो कुरा गर्यौं. Even in vertical tracing also the same thing. It splits to enclose the thyroid gland, forming the false capsule of the thyroid gland. And then from the lower aspect of thyroid gland, it runs forward, or it's get reunited and descend downward in front of trachea. See, it descend downward just in front of trachea, and finally ends by fusing with the fibrous pericardium. Okay. Once again, talking about the horizontal tracing, it is attached to the hyoid bone. From hyoid bone, it descends down to get attached to the oblique line of the thyroid cartilage. Again, further, it descends down to get attached to the more lateral aspect of the cricoid cartilage. From there, it splits to enclose the thyroid gland. From the lower part of the thyroid gland, it again descends down in front of trachea and terminates by fusing with the fibrous pericardium. This is the vertical tracing of pretracheal layer. Now, here, see here, this is the sagittal section through the neck, mainly representing this pretracheal layer. Okay, the hyoid bone, and this is the pretracheal layer, hyoid bone. From hyoid bone, it is attached to the thyroid cartilage. From thyroid cartilage to cricoid cartilage. From there to the tracheal rings here. And see, this pretracheal, this is trachea, and this pretracheal layer is attached to the hyoid bone. From there to the thyroid cartilage. From there to the, it splits to enclose the thyroid gland, and from there it descends down to get attached to the fibrous pericardium. This is the pretracheal layer. And now one important thing to notice here is, can you see this structure? This is also the derivative of pretracheal layer, which is connecting cricoid cartilage with the posterior layer of false capsule of thyroid gland. Okay, so let's say posterior part of the thyroid gland is connected to the cricoid cartilage, which is known as ligament of Berry. And as this ligament of Berry is suspending thyroid gland, so this is known as suspensory ligament of thyroid gland or ligament of Berry, as the Berry was the individual who first identified the structure. So ligament of Berry. Okay, ligament of Berry or suspensory ligament of the thyroid gland is also derived from the pretracheal layer of deep cervical fascia. Okay, remember this thing. And beside, thyroid swelling causes dysphagia because what is the reason behind this is posterior layer of the false capsule is thinner in comparison to the anterior layer. And with the swelling of thyroid gland, the thyroid gland now moves more towards the loose area, or let's say where it can expand. It expand more towards posteriorly than anteriorly and compresses over the esophagus and pharynx, leading to dysphagia. Okay, so remember this important clinical aspect of this pretracheal layer. Then let's go for the third layer, which is the prevertebral layer. So this third layer, prevertebral layer, lies, as the name itself is suggesting, it lies just in front of the cervical vertebra. So this part is the prevertebral layer, which lies in front of cervical vertebra, and it encloses the para and prevertebral muscle of the neck. Okay, so this pre and paravertebral muscle of the neck is enclosed by prevertebral fascia. Now, to talk about the horizontal crossing of prevertebral fascia, like the pretracheal fascia, prevertebral fascia also begins from the deeper aspect of sternocleidomastoid muscle. Okay, prevertebral fascia begins from the deeper aspect of sternocleidomastoid muscle. It forms the posterior wall of the carotid sheath. If you remember the previous slide, the anterior wall of carotid sheath is formed by pretracheal layer. Now, posterior wall of carotid sheath is formed by prevertebral layer. Okay. Once again, I repeat, prevertebral fascia begins from the deeper part of the sternocleidomastoid. It forms the posterior layer of the posterior wall of the carotid sheath, then moves medially, and it splits to enclose the to run in front of the cervical vertebra and get continuous with its opposite side. Okay, this is the prevertebral layer. And then remember, this prevertebral layer has lateral extension as well. Exactly between the scaleneus anterior muscle. This is the, if you remember the cervical vertebra, this is anterior tubercle, this is posterior tubercle, and here this is the foramina transversalis. Okay, so scaleneus anterior, which is attached on the anterior tubercle, scaleneus medius, and levator scapulae, which is attached on the posterior tubercle. So exactly between the scaleneus anterior and scaleneus medius, the prevertebral fascia has lateral extension. Okay, laterally it extends, inseating the brachial plexus, root of brachial plexus, and soft cleavage artery. That lateral extension of prevertebral layer is known as axillary sheath. Okay, it has one very important clinical significance that we will talk in next coming slide. Remember, this prevertebral fascia has lateral extension, which includes the brachial plexus as well as subclavian artery, which is known as axillary sheath. Okay, so this is about the horizontal tracing of prevertebral fascia, and then let's go for the vertical tracing of prevertebral fascia. So, in case of prevertebral fascia, vertically or superiorly, the prevertebral fascia is attached at the base of the skull. If you notice this, this is the sphenoid body of the sphenoid, sphenoidal air sinus. Okay, within this part is the clivus. So almost at the base of the skull is the attachment of prevertebral, superior attachment of prevertebral fascia. Okay, and then this prevertebral fascia descends downward. Then it splits into two layers: the anterior layer and posterior layer. Anterior layer is considered as alar ligament, and posterior layer is known as posterior lamina, or in some time the posterior layer is what considered as the true prevertebral fascia. Okay, once again I repeat, vertically the prevertebral fascia is attached superiorly to the base of the skull, and inferiorly it gets split into alar ligament and alar lamina and posterior lamina. Okay, this alar lamina finally gets fused with the let's see here in this part. This alar lamina get fused finally with the buccopharyngeal fascia, which is the next modification of deep cervical fascia. Okay, while the posterior lamina, which is the true prevertebral fascia, get fused with the anterior. See, these are the cervical vertebra and thoracic vertebra. Okay, see, this is representing the third thoracic vertebra. So this green color structure just in front of the body of the vertebra is representing anterior longitudinal ligament. We know anterior and posterior longitudinal ligament. Okay, so finally this posterior lamina get fused with the anterior longitudinal ligament at the level of about third to fourth thoracic vertebra. Okay, this is about the extension of the prevertebral fascia, and this prevertebral fascia is somewhat continuous with the superior mediastinum. So this is the vertical tracing. Once again, I repeat, superiorly it is attached to the base of the skull, and inferiorly it splits into alar lamina and prevertebral lamina. Prevertebral lamina gets fused with the anterior longitudinal ligament at the level of third to fourth thoracic vertebra, while alar lamina get fused with the buccopharyngeal fascia anteriorly. Now, an important clinical aspect to know within this prevertebral fascia is we have talked about like prevertebral fascia has lateral extension, which is known as axillary seat. Okay, and this axillary seat is one which includes the brachial plexus as well as subclavian artery. So, due to the extension of prevertebral fascia as axillary fascia or axillary seat, infection of vertebra, like in case of tuberculosis of vertebra or caries spine, vertebral spine, okay, this may lead to spread of pus or spread of infection to axilla because it is continuous with the axilla. So the infection may spread up to axilla and through the axilla up to bend of elbow. Okay, even up to bend of elbow, this infection may spread from the vertebral or any vertebral infection may spread from axillary seat to the axilla and from there even up to the bend of elbow. Okay, so this is how the spread of infection is assisted by this prevertebral fascia. The next layer or the fourth modification of deep cervical fascia is the carotid sheath. This carotid sheath is a tubular fascial sheath which includes the nerve and blood vessels. So, the facial compartment formed by this carotid sheath is considered as neurovascular compartment. Okay, and talking about the extent of this carotid sheath begins right from the base of the skull. Okay, here this carotid sheath also begins right from the base of the skull up to the mediastinum where it gets fused with the fascia covering or the adventitia covering the arch of aorta. Okay, so remember talking about the extent of carotid sheath, it begins from the base of the skull up to the level of arch of aorta. This is the extent of carotid sheath. Then talking about the content of carotid sheath. So see here, this is the statal section through the carotid sheath showing its content, and this is transverse section through the carotid sheath. And remember, the content are internal jugular vein, common carotid artery which divides into internal and external carotid artery within the carotid sheath, and then vagus nerve. Okay, this is the vagus nerve. And remember, vein is most laterally placed. Vein is lateral in position, artery is medial in position, and more posterior placed is the vagus nerve. Vagus nerve is at the posterior plane than artery and vein. But remember, artery is present medially and vein present laterally within the carotid. Okay, so this is the content of carotid sheath. And remember, anterior wall of carotid sheath. This is the anterior wall of the carotid sheath, and this is the posterior wall of the carotid sheath. Posteriorly, carotid sheath is related with important structure, which is the sympathetic chain, and anteriorly, within the anterior wall of the carotid sheath, this loop of nerve ansa cervicalis is embedded within the anterior wall of the carotid sheath. Okay, this ansa cervicalis is actually a loop of nerve which is part of the cervical plexus. Okay, so this is about the content and extent of carotid sheath. Now talking about the formation. Now you people have to mention the formation. How carotid sheath is formed. I've already mentioned two and more times. This carotid sheath is formed by anterior wall of the carotid sheath is formed by. Please think out. Anterior wall of the carotid sheath is formed by pretracheal fascia, and posterior wall of the carotid sheath is formed by prevertebral fascia. Okay, so pretracheal and prevertebral fascia forms the anterior and posterior layer of the carotid sheath. and then it is situated just deep to the sternocleidomastoid muscle. Okay, just deeper to the posterior part of sternocleidomastoid muscle is the content of cartilage. So now, when you go for the demo of anterior and posterior angle, you will see, you will be able to see this cartilage sheath and its content. Okay. Then the fifth modification of investing layer is buccopharyngeal fascia. And remember, buccopharyngeal fascia here, it is represented by this dotted line. Okay, it is represented by this dotted line because it actually is ill-defined membrane, and this buccopharyngeal fascia actually is considered as epimysium of the pharyngeal muscle. We know pharyngeal muscles which has circular and longitudinal muscle. So this buccopharyngeal fascia actually is considered as the epimysium of the pharyngeal muscle. Okay, and this is ill-defined membrane which extend right from the superiorly from the base of the skull. Okay, talking about the extent of buccopharyngeal fascia, superiorly it is attached to the base of the skull. Inferiorly, it continues with the superior mediastinum in the form of loose connective tissue. Okay? Inferiorly, it continues with the superior mediastinum, and lateral extension is laterally this buccopharyngeal fascia spreads over the superior constrictor muscle. Okay, here superior constrictor muscle which is present superiorly here. Laterally, buccopharyngeal fascia spread over the superior constrictor muscle, from there to the pterygomandibular area, and from there to the lateral aspect of face over the bossinator muscle. Okay, this is the lateral extension. Talking about the extent, superiorly it extends from the, or it is attached to the base of the skull, and inferiorly it continues with the superior mediastinum. While laterally on both sides extend anteriorly over the superior constrictor muscle, the pterygomandibular raphe, and it reaches up the lateral aspect of face over the bossinator muscle. Okay, this is the attachment of the buccopharyngeal fascia, and as the name itself suggests, it lies just behind the pharynx. Okay, representing the epimysium of the pharyngeal muscles. And to talk about the applied aspect of this buccopharyngeal fascia, as it forms the anterior wall of retropharyngeal space. Okay. Retropharyngeal space means the space present just behind the pharynx, and we know this buccopharyngeal fascia is present just behind the pharynx. So it forms the anterior wall of the retropharyngeal space, and infection in this space may spread directly into the along the fascia into the superior mediastinum. Okay. It may spread up to superior mediastinum because it is continuous with the superior mediastinum. Yeah, I think superior mediastinum has been missed in this line. So this is about the buccopharyngeal fascia. Then the sixth modification of cervical fascia is the pharyngobasilar fascia. Don't get confused between buccopharyngeal fascia and pharyngobasilar fascia. Okay, buccopharyngeal fascia is considered as epimysium of the pharyngeal muscles, which extend right from the base of the skull up to the superior mediastinum. But remember, pharyngobasilar fascia is the smallest one. See, this green color is representing the pharyngobasilar fascia. Okay, and this pharyngobasilar fascia is known as pharyngeal aponeurosis because it is considered to connect the pharyngeal muscle with the base of the skull. Okay, buccopharyngeal fascia is considered as pharyngeal aponeurosis because it is supposed to connect the pharyngeal muscle with the base of the skull. And this pharyngobasilar fascia lies deep to the muscles of pharynx. Okay, talking about the attachment of pharyngobasilar fascia, superiorly pharyngobasilar fascia is attached to the base of the skull. So here, superiorly it is attached to the base of the skull, and inferiorly it just gradually become areolar tissue. Okay, inferiorly it starts to form the loose areolar tissue, and finally get lost somewhere within the superior constrictor muscle. Remember, it does not extend beyond the superior constrictor muscle. Okay, this is about the pharyngobasilar fascia. Now, to know some important spaces present within this. First one is the retropharyngeal space. So see here, this is pharynx here, okay, and here buccopharyngeal fascia is represented by this one, just behind the pharynx. This dark line is representing the buccopharyngeal fascia, and here this red line is representing the anterior lamina or alar fascia of prevertebral layer. Okay, and this one is the posterior lamina, which is known as prevertebral fascia itself. We have talked about prevertebral fascia, which splits to form alar lamina and prevertebral fascia. So, just in front of alar lamina and just behind the pharynx or buccopharyngeal membrane, this space is known as retropharyngeal space. Okay, and then retropharyngeal space is considered as potential or dead space that lies behind the pharynx, and the main function of this retropharyngeal space is to provide expansion of pharynx. Okay, to provide say space for expansion of pharynx, and it extends behind the pharynx up till bifurcation of trachea. Because we know alar fascia finally get fused with the buccopharyngeal fascia anteriorly up to the level of all till the bifurcation of trachea. This alar fascia get fused with buccopharyngeal fascia, limiting the lower limit of the or forming the lower limit of retropharyngeal space. Okay. And talking about the applied aspect of this space, in pyogenic infection, pores may extend down into the mediastinum and may extend laterally behind the carotid sac, because this retropharyngeal space is bounded laterally by the carotid sac. Okay, superiorly, it extends from right from the base of the skull and inferiorly up to the bifurcation of trachea, which is present within the this bifurcation is present within the mediastinum, junction between superior and inferior mediastinum. So infection or pus may spread down up to the mediastinum from this retropharyngeal space. So this is the sagittal section through the retropharyngeal space, and this is the transverse section through the retropharyngeal space, which can be considered here. This is trachea, this is pharynx or esophagus. Okay, and just behind the pharynx here, this is the retropharyngeal space, which is limited anteriorly by this buccopharyngeal fascia, posteriorly by the alar lamina of the prevertebral fascia. Okay, and laterally this is limited by this carotid sac. So this is about the retropharyngeal space. The next one and the important one here is the danger space. So what actually is this danger space is, this danger space actually lies between the retropharyngeal space and prevertebral space. Okay, see here in this picture, here, this yellow color is representing this retropharyngeal space. Okay, retropharyngeal space, and this orange color is what representing the danger space, and this darker orange color or reddish color one is representing the prevertebral space. Okay, so this danger space is present just behind the retropharyngeal space and in front of the prevertebral space. But remember, according to some author, danger space is considered as itself as a part of the prevertebral space only. Okay. So, for your concept, remember it is present between retropharyngeal space and prevertebral space. So, and it extends from right from the base of the skull up to the posterior mediastinum up to the level of diaphragm. So, throughout the mediastinum, it is extended from base of the skull to the diaphragm. Okay, and obviously, infection in this danger space may spread easily up the mediastinum. And this danger space is considered as why it is considered as is because it is actually filled with loose airway tissue. This danger space is actually filled with loose airway tissue, and because of this, infection within this space is spread easily and rapidly. Okay, the infection, the rate of spread of infection is very rapid in this space, and it may result in mediastinitis or empyema or even sepsis. Okay, and in severe condition, it may even lead to death of an individual because of its rapid spread, and that may lead easily into sepsis, may cause death of an individual, and that's why this space is considered as danger space. Okay. Then next space to know is lateral pharyngeal space, and the name itself is suggesting lateral pharyngeal space that lies laterally to the pharynx. Okay, so here this is the transverse section through the oral cavity at the level of pharyngeal space, lateral pharyngeal space. So here this is the level 1 lateral pharyngeal space. Okay, now to get oriented, here this is the anterior aspect with the tip of the tongue here. Okay, anterior aspect, and this is the posterior aspect. Now lateral pharyngeal space is actually that lies on each side of the pharynx, extending up to the hyoid bone. Okay, it extends up to the hyoid bone. Talking about the boundary of this triangular, this area is the lateral pharyngeal space, which is bounded medially by pharynx. See, medially it is bounded by pharynx. Okay, then posterior laterally it is bounded by parotid gland, Anterolaterally, it is bounded by medial pterygoid muscle along with the ramus of the mandible. Okay, anterolaterally by medial pterygoid and ramus of mandible. Posterolaterally by parotid gland. Posteriorly, it is bounded by carotid seed. Okay, here in this diagram, carotid seed is not seen here, but posteriorly, it is bounded by carotid seed. Above, it extends up to the base of the skull, and below, it extends up to the level of height. Okay, once again I repeat, lateral pharyngeal space is bounded medially by pharynx, posterolaterally by parotid gland, anterolaterally by medial pterygoid along with the ramus of the mandible, then posteriorly by carotid seed, superiorly by base of skull, and inferiorly it extends up to the level of hyoid bone. Okay, and talking about the content of this triangle or this space, it contains branches of maxillary nerve and vessels. Lateral pharyngeal space contains branches of maxillary nerve and vessel. Okay, and applied aspect of this lateral pharyngeal space is infection of palatine tonsil. Actually, palatine tonsil is present somewhere here anteriorly on anterior aspect of this lateral pharyngeal space. Okay, so infection of palatine tonsil may spread easily up to the lateral pharyngeal space, and from lateral pharyngeal space, infection even may spread up to the parotid, submandibular, and other spaces around the pharynx. Okay, and this might be one possible root of Ludwig angina. So what this Ludwig angina actually is? Ludwig angina is cellulitis or inflammation of submandibular space. Okay, so see here, this one is the submandibular and this one is the sublingual. So from lateral pharyngeal space, the infection may spread to the submandibular, sublingual, and other spaces around the jaw and pharynx. So cellulitis and inflammation of submandibular space, usually starting from maxillary space or let's say lateral pharyngeal space. And what is the difference here is in case of Ludwig angina, the infection is spreading through the facial plane, not because of lymphatic system or not because of lymphatic vessel. The infection is spreading through this facial plane. Okay, leading to Ludwig angina, and this is an emergency condition, life-threatening condition that may require tracheostomy. Because of this infection or spread of infection to different spaces, it may result in obstruction of airway. So as shown here in this diagram, because of swelling of tongue and other area, it may result in obstruction of the airway tract. And for that, or for because of this life-threatening condition, it may even require tracheostomy. Okay, so this is what about the Ludwig's angina, and we are done with this cervical fascia. So I hope you people are clear. Any confusion?